Pleasure to be here in this symposium, and I'll be talking about a subject I've been working with for a while. It's functional imaging of striated muscle, and I'll be talking about the application of perfusion and diffusion and evaluation of the muscle, and then I'll be focusing on some technical aspects on the application of functional imaging on a muscle for muscle evaluation. But the first question you should ask yourselves is why bother? And then the problem here is that sometimes we're very limited with conventional MR imaging for characterizing muscle injury and following up patients with muscle diseases. So, which is why people started to look into functional imaging in order to provide more elements for muscle characterization and also to allow us to have quantitative parameters that will be easier to make diagnosis and patient follow-up compared to qualitative subjective analysis. Perfusion imaging, it's one of the techniques that have been evaluated for this purpose. And then this technique is interesting because many muscle diseases are related to changes in muscle vascularity, and then it would be a good idea to have a better appreciation of muscle enhancement and vascularity related to pathology of many different types of muscle diseases. And diffusion-weighted imaging is a technique that provides us a way to evaluate non-invasively the microstructure of muscle fibers, which is also important for characterization of muscle diseases. The problem is that these techniques have many technical difficulties that may alter the results. And then there are also a very tricky portion is that post-processing is something that is not standardized, and it can really change the results. So these two difficulties have to be taken into consideration when you start using functional MR imaging. And then there are many diseases, muscle diseases, that can benefit from this type of imaging. There's myositis, trying to improve characterization and then to better guide biopsies. There's muscle strains that maybe we could have a better appreciation on how much time does the patient needs to recover, and then the real extent of muscle damage, the amount of extent and the muscle dystrophies, and then maybe an easier and more reproducible diagnosis for chronic exertional compartment syndrome. So this is just an image to, you probably see this every day. This is the case of myositis. It's hyperintense in T2. There's a little bit of fat replacement when you look at fat images. And then this is completely non-specific because there's many causes of myositis, and they all look like that in MR imaging. And sometimes you're lucky, and you can have a case like this when you have a specific enhancement in the perimuscular fascia, and then this can be related to eosinophilic fasciitis or dermatopolymyositis, but this is very rare, and in most of the cases we're very limited on the evaluation with MRI. Same scenario here, but a different case, but it's pretty easy to see the injury. You can see the hamstring injury there in the myotendinous junction, and you can see that there's a little anomaly in the morphology of the tendon at that position. But the real extent and muscle damage is hard to appreciate, and that is somewhat difficult to correlate conventional morphologic imaging with time to return to activity. And then there are many papers on that, but it still lacks. We still lack information and criteria to better judge on that. So muscle is another thing for musculoskeletal systems, and muscle can be used as a standard of reference when you're evaluating pathology other than muscle diseases, like in tumors. And then this is very important because musculoskeletal system, it's very widely spread in the body, and the physiological conditions in the tip of the finger are very different from those in the shoulder or in the hip or in the foot. And then this is why we need, in some cases, a standard of reference. And then muscle is thought to be a good one because it has a ubiquitous distribution. We think it, at least we thought it had a little variation in the composition, and then it's somewhat homogeneous. This is why many papers use muscle as a standard of reference for the evaluation of other musculoskeletal pathology. But the problem is there's a lot of sources for variation in the parameters that we acquire with functional imaging. And they are, first of all, related to physiologic variation, because depending on level of physical activity, gender, all that can influence on the physiology of muscle. The structure of the muscle is not as simple as it seems, because there's tendon, there are nerves, there's a little bit of fat, that is, there are vessels inside the muscle, and all that sort of complicates things. And then there's something I'll be talking a little bit more in this presentation. It's a technical variation related to the techniques that we use for functional imaging, related to suboptimal acquisition protocols, or fault of ROI positioning techniques, or which type of parameter that we use, and even the post-processing tool that is available for the evaluation of this data. So first of all, muscle perfusion can be confusing because you have multiple options for protocol acquisition, and then there are questions about the reproducibility and the interpretation of the data that we acquire. So you may feel confused when you start doing like a perfusion, MR perfusion, or any other type of perfusion. And then the way we look at this is that it really depends on the kind of perfusion parameter you're looking for. So, there are basically three types. There are visual parameters, there are semi-quantitative parameters, and then there are what's called generally permeability parameters, each one with advantages and disadvantages. So visual parameters are interesting because they're very readily accessible. You just do the acquisition, and you look at images, and then you can get more information than only a late enhanced acquisition after it's a T1 fat sat gadolinium. And then you need to evaluate this images a reference and then what we usually do is look at the artery to have an idea of how fast and how intense other structures are enhancing. So you can see in this case, there's very little to see in this T2-weighted imaging in the calf muscles. If not a little bit of hypertrophy. But when we do perfusion, this is before injection, and then arterial phase and venous phase. And then if you build a area under the curve map, just by looking at it, you can clearly see there's something wrong going on the right side, as it is much more enhanced than the left side. So only by looking at it visually, you can already extract more information than a conventional late gadolinium enhancement acquisition. Semi-quantitative parameters are all related to all extracted from the intensity to time graph. And then you can look at many things. So in this graph here, you can see arterial enhancement in pink, and then target enhancement in green. This is a tumor. So if you look at the enhancement slope, you can look at maximum enhancement. You can look at the enhancement integral, or the area under the curve. And I'd like to call your attention to this parameter, which is, in my opinion, and in the opinion of many papers that have been published, is the most robust parameter that we have so far for perfusion in MR imaging. And then there's also time-related parameters, as we have time to peak. And the one that is most useful in musculoskeletal imaging is the delay between the arterial and the target peak, because musculoskeletal system, we are evaluating areas of the body that are different, that are in different distances from the heart. So we can't have only one referential. You need a local referential for time parameters. So which is why this parameter is interesting. And then there's obviously permeability parameters that are interesting because they are related to the estimation of the concentration of gadolinium in the tissue. Not only in the tissue, but inside the vessels and the extravascular, extracellular space. And then this is interesting because since we're dealing with a concentration estimation, theoretically, we can compare data from one patient to the other, which is not the case for the other parameters because they're subjective and subjected to variations, interpersonal variations. So this is why there's a lot of people interested in perfusion parameters. And on the top of all that, we can have an idea on the structure of the vessel wall by looking at parameters that correlate well with vascular permeability. Right. So these are, and then you need T1 mapping for these parameters, but I'll talk about that later on. So this slide sort of summarizes the main difficulty, in my opinion, for the application of perfusion for muscle evaluation. And this is the variation of the perfusion parameter in normal muscle. So if you look in the upper lines there, you'll see that this is semi-quantitative parameters, and already with those parameters, the variation in normal muscle, once again, is very high. The best parameter is area under the curve, and this is higher than 30% variation in normal patients. Then if you look at permeability parameters, then it's even worse. It goes up to 70% of variation, 60% if you look at VE. And then in our study, we showed there's a significant inter and intra-patient variability in the parameters that we acquired. This means that if you place an ROI in the rectus femoris, you get one number, and if you get in the same patient, you place an ROI in the vastus lateralis, and it's different. And this is a serious drawback for the application of this technique in clinical practice. And if you do that, you have to think of ways of coping with this variation. Right. The first way to reduce this is to have a robust protocol. I believe we need to do a very big effort to have same parameters, similar machine settings, similar coils, and all that. But there are other things you should look into too. So if you look at the temporal resolution range, as you know, temporal and spatial resolution and MR imaging are very closely related. So if you, this depends on the parameters that you're trying to evaluate. So if you're looking at permeability parameters, you probably use an intervolume delay of 5 or even less, because you need that to have a good fitting for the calculations and the after data acquisition. But if you're looking at visual semi-quantitative, you can have a little bit more, and then you can work with around 7 or 10, which should be fine for semi-quantitative and visual parameters. What's the injection delay? This will vary depending on the position that you're evaluating the musculoskeletal system. So as it varies, the location. So the only thing that you should avoid is what happened in this graph here. So the first volume of the acquisition is in the middle of the arterial enhancement. And this should be avoided because this will mess up all the calculations, especially if you're looking at permeability parameters. So you have to make sure you want to start before arterial enhancement. And in our practice, this is around 10 seconds if you're doing central joints like the shoulder or hip. And it goes closer to 20 seconds if you're doing lower limb imaging. The amount of contrast that we need is standard. I'm not aware of any studies that show that we need higher dose. So we do standard dose in our institution. And the optimum acquisition length is something to consider too, because especially in muscle, the enhancement pattern is progressive enhancement. And then if you have a too short of acquisition, you don't know what's happening next. And then you have not a very good idea where the enhancement peak is. And then worst of all, you don't have a washout phase, which will mess up all the calculations for permeability parameters. So if you're looking at those permeability parameters, you need a longer acquisition, 7 to 10 minutes at least. And then you're not obliged to do a single acquisition, but you should acquire maybe late phases around 10 minutes in order to be sure to have a washout phase for your calculations. So few tips for ROI positioning. You should definitely consider looking at morphologic imaging to avoid vascular structures, tendon, fatty areas. And then in our experience, if you increase the size of the ROI, you improve a little bit more reproducibility and variability of the acquired parameters. It's not a lot, but it's around 6 to 10% of improvement in the reduction in variation rate. So you should look at morphologic images and try to get the larger ROI as possible. At least this is our results. So post-processing is also very important. So I think the best way to look at this is you need a software that provides a voxel-based analysis so that it can calculate parameters in every single voxel, and then this way you'll be able to better place your ROIs. And if you decide to do a volumetric evaluation, that is possible too if you use a voxel-based approach. And this should include the T1 mapping, because if you don't have this approach and you do this approach only for the calculation of the parameters, and if T1 mapping is not considered, your calculations might be false. So you need a software, there's software that provides many corrections, such as motion correction. And then another very important issue is AIF, arterial input function. And then ideally, you have to find a sort of semi-automatic way to place that, because you know that a lot of variability in perfusion comes to changes in the selection of the arterial input function. There are multiple pharmacokinetic models. The one that's most frequently used is Tofts model, extended Tofts model. But the only thing you have to see here is that you have to use parameters acquired with the same model, but this is pretty straightforward. So T1 mapping, why do we need it? We need it because if you want really to compare data from different patients, if you don't use T1 calculation, you sort of increase, double the variability of the parameters that you acquire. So if you want to compare data from different patients, you definitely need T1 mapping, because this will allow us to better estimate the concentration of gadolinium, and this will improve the comparability of the data that you're looking at. So there are many ways to do that. The thing that you must look into before you start doing anything is that what method is acceptable by your post-processing software, because it changes. So if you decide to use variable flip angle, which is faster, but it's more sensitive to field heterogeneity, that's good, but you need to know that your software does that. If you use inversion recovery, which is very more robust but takes more time, you have just to make sure it copes with your post-processing tool. And please keep in mind that there's also a physiological variation in the muscle T1 values, about 13%. And as you can see in this T1 map, that it's not very homogeneous inside muscle, so that should also be considered. So, in the end of the presentation, I'll talk about diffusion-weighted imaging and a few on the advanced, few words on the advanced techniques that are done with diffusion-weighted imaging. Obviously, the classic technique suffer from a few difficulties. They're related to the EPI acquisition that distorts images related to heterogeneities in the magnetic field if you're imaging extremities. So for central joints, it's fine, but if you're looking at hands and forefoot, it's going to be hard. So far, the recommendation for classical protocols include 3 B values, and you start for a B value of around 50 millimeters squared per second. This is to avoid perfusion influence. And then you should look, if you're looking at muscle, again, at quantitative data, much more than visual analysis. And this is true for other organs too. I was seeing a presentation on the prostate today, and then it's much better when we look at it quantitatively, and the reproducibility is much better. So our evaluation is from these cohort of 76 patients, and then we analyzed the variation of ADC values in normal muscle in different muscles of the body. And then again, it's similarly to perfusion. There's a significant variation on the ADC values of normal muscle. Variation was similar in females and males. We have a mean ADC value that is presented there, but the variation is still considerable. One thing you have to consider is that ROI positioning and then the calculation of the ADC is also important for the quality of the results that you acquire. And then there are a few things that we already know. So ADC values are influenced by the size of the ROI. So if you're doing scientific work, you should find ways to quantify the size of the ROI and have it sort of somewhat homogeneous throughout your cohort. And there's a general tendency, especially if you're doing with heterogeneous tissues such as tumors, the smaller the ROI, the lower the ADC. And this sort of increases the diagnostic performance when we look at the oncology data. But there's a trick there, because if you go very low and if you start looking at a voxel-sized ROI, so let's say if you do semi-automatic measurements and then you have the software identify the lowest ADC in that tumor or in that area, this will reduce the sensitivity because there's a lot of variation due to tissue heterogeneity. So you look at calcification, tendons, flow voids, all that will change the ADC values, and this should be considered when you do ADC analysis. So small voxel, but small ROI, but not too small. Right. And then I'll finish by talking a little bit about the new methods, diffusion-weighted imaging-based methods. And then those new methods are more and more available in clinical practice, and then you can use them by increasing the number of direction gradients or the number of B values that you acquire in your protocol. So you need a protocol change to benefit from these new techniques. But if you increase the number of gradients, you can look at the diffusion tractography imaging, diffusion tensor imaging, which can build you can build tractography images, 3D images that show the direction of muscle fibers, and you can look at an intravoxel in cohort motion that will separate by B-exponential analysis the influence of perfusion and the true diffusion in the tissues that you evaluate. So this is also something that you should look into. And then you can also use calculations with multiple B values to extrapolate the calculations of very high B values, looking at B values like 2,000, 3,000, without the compromise that you have to do for signal-to-noise ratio. So those new techniques are very interesting. There are a lot of clinical work with those. So if you look at diffusion tensor imaging, you can see that other parameters such as mean diffusivity and fraction of anisotropy vary related to exercise, early muscle damage. So you can see that in this paper showing that after a marathon, there is small early degree muscle strains that correlate to increases in diffusivity and increases in the fraction anisotropy. And then the opposite also happens when you have chronic exertional compartment syndrome, in which way you have a sort of amputated response to exercise in the affected compartment. So all that has been shown, and there are clinical studies from our colleagues in Switzerland showing this increase in perfusion calculated with intravascular and cohort motion in the subscapularis muscle during exercise inside the MR scanner. Right, so I'm already behind my time here, I'm sorry. So I'd like to say that the functional parameters that we acquire, they tend to be variable in normal muscle, so you should definitely take care of that if you're evaluating this. You need a very solid acquisition protocol if you're looking at functional imaging, so you really need to give some thought on that. And then if you're looking at perfusion, what is the best for clinical practice so far is semi-quantitative parameters, especially area under the curve, with some papers showing the benefit from that parameter. And if diffusion, we put a lot of our hopes in the future of advanced techniques such as diffusion tractography or intravoxel and cohort motion. Right. Thank you. Sorry for the delay. Thank you.
Thank you, Dr. Teixeira, for this beautiful presentation. We have time for one short question. Is there a question from the audience? I can't see it. Yes. Perhaps can this technique improve the quality for our muscle biopsies? What do you think?
I think this still needs, we still need more research to be sure about this, but again, this follows the same rationale. So once you increase the number of parameters and the ability to characterize tissue, you'll probably be able to better select the target for biopsies. So I think I cannot give you a definite answer right now, but I think this is something that we should definitely look for in the future. Yeah. Thank you.